This lecture is on Chapter 9, Articulations and Joints. The first slide that we're going to look at is the relationship between mobility and stability. So the chart starts out with the joints that are considered to be the most mobile, such as the glenohumeral joint or the shoulder joint. And we see that when a joint has an increase of mobility, then we also are going to have a decrease in stability in the joint. Moving next, we have the hip joint. Most consider the hip joint to be fairly stable, but we can see that it has a greater amount of mobility, which will then decrease its amount of stability. The elbow joint, which has not only flexion and extension, but also supination and pronation, has an equal amount of mobility as related to stability due to its structural composition of the olecranon process and the olecranon fossa. Moving down, we are going to then get into the protective mechanisms of joints, such as the intervertebral joint. So obviously, the intervertebral joint's main job is to protect the spinal cord. So therefore, we see an increase of stability and a decrease of mobility. And the most important structure that we're protecting is found in the suture of the skull, which is the brain, protecting the brain. So we obviously see a decreased amount of mobility and an increase in stability. So we'll be breaking these joints up based off of the amount of movement that each joint has and some structural components that each one have individually. So the first one that we saw in the last slide is the suture. This is specifically only located in the bones of the skull. So a fibrous joint, we don't really see that much movement. It's a lot of stability and very low amounts of mobility. The next one would be the syndesmosis. These bones are usually connected by a series of ligaments. So we'll see a series of ligaments in the distal portion of the connection of the ulna and the radius and the proximal connection. So we'll see a series of ligaments that are helping to connect these. And also we see an interosseous membrane, which is also called a syndesmosis. This allows for the radius to stay in close proximity to the ulna during supination and pronation. And finally, the last one we see is the gomphosis. And the gomphosis is what binds the teeth to the bony sockets in the maxillary and the mandible. And this also has a little bit of cartilaginous joint properties. And we can see that they're usually bound in the lower aspects of the socket going into the mandible or the maxillary bone. They also have a series of connecting ligaments. In this case, we see it, they're called periodontal denticular ligaments. And these periodontal denticular ligaments are also what are holding the crown of the tooth in relationship to where the mandible or maxillary bone is coming in to hold its shape of the tooth. So moving up, we're going to see a little bit more movement, and which means that if we're going to increase mobility, we're going to decrease just slightly in stability. So the first grouping is going to be called the synchondrosis. This contains hyaline cartilage. We've seen hyaline cartilage in the epiphyseal plate and long bones. We also see this in the costochondral joints located here, the connection between the ribs and the sternum. The next one is the symphysis, and this cartilaginous joint is going to contain a fibrocartilage. So a fibrocartilage, just as a reminder, is a cartilage that lacks an outer perichondrium or an outer membrane. Its main function is for cushion and support. The first one that we see, the symphysis. We see the articulating bones of the vertebrae interconnected with these intervertebral discs, and these intervertebral discs are what allows for articulation between the two bodies of the vertebrae. And again, they're composed of fibrocartilage. We also see it, the symphysis, with the pubic symphysis. The os coccyx, or the pelvis itself, is all one unit, but the individual pelvis is separated. The left and the right side is separated by the pubic symphysis, which is also composed of fibrocartilage. So the most mobile joint that we have in the human body is called the synovial joint. And this is just a general picture of a synovial joint. And one of the most important aspects of the synovial joint is going to be the synovial membrane. And this synovial membrane is going to cover or create this pocket. So it goes all the way around these two articulating bones, and it is going to produce fluid. These cells inside of the synovial membrane is going to produce a fluid called synovial fluid. It's important, synovial fluid, in these synovial joints for lubrication. It helps nutrient distribution and also aids in shock absorption. The next part we see is the articular cartilage. That's another common characteristics of a synovial joint. It resembles the hyaline cartilage. Hyaline cartilage's main function is to provide a frictionless movement between two articulating bones. They do not have a perichondrium, and the matrix is going to be also composed of nutrient-dense materials for the cartilage. So the next one is also what we're looking at, some other characteristics of synovial joints. And some of the most important aspects of synovial joints is all of their accessory type of components. So the first one we'll look at are the bursa. In the knee, we have, it can be anywhere from 8 to 11 bursa, and these are usually located in areas where we see a lot of movement. So the first one we'll start out with is the gastrocnemius, and the gastrocnemius insertion is, or origin, is going to be in the posterior surface of the femur. And these bursa are small fluid-filled pockets inside, are composed of connective tissue that contains synovial fluid. So it allows for the contraction of the gastrocnemius to have some synovial fluid located around there. We also see it located in the prepatellar bursa. So the patella retinaculum is going to go over the top and eventually connect into the tibial tuberosity. But this, every time the quadricep contracts, we'll see the patella moving proximally and distally, and these bursa help lubricate that movement. We also see it down in the patellar retinaculum called an intrapatellar bursa, and we also see it located in the proximal or distal surface of the femur called the suprapatellar bursa. But their main job is to make sure that we have a frictionless movement between all of these moving parts in the synovial joint. Over here we see in a synovial joint, we see different components such as ligaments and tendinous sheaths, and their main job when we look at the common flexor tendinous sheath is we'll see the flexor pollicis longus muscle and the flexor digitorum profundus muscle. They'll terminate a little bit more proximal along the humerus or the ulna, and then it turns into a series of tendons, and these common flexor tendinous sheaths just allow for a nice straight line of articulation, and it allows for the tendon to contract and move in its own individual tendinous sheath. So it allows for a little bit more dexterity for the contraction of these muscles. We also see fat pads. That's the last part. So we see a lot of fat pads in the area of the knee, and fat pads are necessary for cushioning and support. In the next slide, we just simply have the classifications of all of the different types of joints. So the first one we're going to look at is going to be the plane joint. So we see the plane joint, it has a flattened or slightly curved face. The ligaments are usually preventing or restricting movements. When we're looking at the plane joints, we can see this in the different types of carpal bones that are located in the wrist. And these carpal bones are interconnected by a series of ligaments, but it gives us the ability to have an increased range of motion in the wrist joint. The next one we'll look at is going to be the hinge joint. With a hinge joint, it permits angular motion mostly in a singular plane. So when we look at the hinge joint, the primary motion of the elbow, or another example would be the knee, would be flexion and extension. Even though in the knee we do see a little bit of rotation, and also we see a little bit of rotation in the elbow joint, its primary job is, or singular angular motion is going to be flexion and extension. The next one will be the pivot joint. The primary area we see a pivot joint is between C1, which is called the atlas, and C2, which is called the axis. When we're turning the head left and right, the C2 is going to stay mostly stationary, and it's going to have the dens of its axis, and we're going to see C1 rotating on top of C2. So it has motion primarily in one singular plane called a rotation. The next joint will come down here to the metacarpal bone, which intersects with the proximal phalanx. And this condylar joint, it has an angular motion which occurs in two planes, and it occurs along the length of the oval. So here we can see, say for instance in the proximal phalanx, we see that we have a concave surface, and then in the metacarpal bone we're going to have a convex. So these two surfaces allows for flexion and extension, and also a little bit of abduction and adduction. The difference between a condylar joint and a saddle joint is just how we see the joint rotated. We usually see this in the first metacarpal bone, so in the thumb, and this concave along one axis and convex along the other. It allows for angular motion and an interlocking connection, which permits a stronger joint, but it also allows for circumduction. So we can add that rotation into the saddle joint. And finally, the one that has the most range of motion is called a ball and socket joint. Ball and socket joint in this example is going to be your hip joint, but we also see it in your shoulder joint. So the most important aspect of ball and socket joints is it has a combination of angular motion and also rotational movements, including circumduction. And previously in the slide we talked about how a ball and socket joint is going to have an increase amounts of mobility and a decrease amount of stability. And it's primarily due to the increases of motion such as rotation and circumduction. So when we look at the joints of the axial skeleton, the one that we particularly pay attention is the temporomandibular joint. And this one is actually poorly stabilized, and it's weak in the anterior direction and in any of the lateral directions, so moving to the outside. So when we're looking at this, we're particularly paying attention to the head of the mandible articulates with the articulating tubercle of the temporal bone. So here we have the temporal bone, and then here we would have the mandible, and then it creates this area that we're going to be discussing, like an articular capsule, which is composed of fibrocartilage. It has a very loose connection, so which promotes an extensive range of motion. So in the temporal bone, we have first the articulating surface of the temporal bone here, and then in the mandibular surface, we're going to have the articulating surface of the mandible. And in between that, we're going to have this component called an articular disc. And this articular disc is composed of fibrocartilage, and again, it just separates the temporal and the mandibular bone, and it's going to create these two separate chambers. This is an area that we can see that can be locked, grinding of the teeth. We can also see it called a lockjaw. So to help support this joint, we have a series of ligaments. So the first one is the sphenomandibular ligament, which is obviously, when we're looking at it, it's going to connect, when we're talking about ligaments, it's going to connect two bones. So it's going to connect the mandible to the sphenoid. And then we have the stylomandibular. So this ligament is going to connect the bone of the styloid process with the mandible. And the last one is the temporomandibular ligament. And this temporomandibular ligament is actually going to go over the top of this articular disc, and it's going to connect the temporal bone to the mandible. And then again, inside of that, we'll see the articulating capsule. So ligaments are just going to provide some form of support for the movement of the mandible with the temporal bone. So the next one we're looking at is the intervertebral articulation. And again, with the intervertebral articulation, we are going to lose some mobility, and we can see that we're going to lose some mobility for protection of the spinal cord. So the spinal cord is actually going to run between the anterior and posterior longitudinal ligament. And you can see that the vertebral discs, or the vertebral disc and the bones of the vertebrae are all connected by a series of ligaments. So these ligaments are going to fire during excessive ranges of motion. So if you end up going into an excessive range of motion, these ligaments will fire to protect the spinal cord. So the first one we'll look at is going to be the intervertebral disc itself. So it's composed of two different types of components. The first one is the annulus fibrosus, and the annulus fibrosus is a concentric ring, and this concentric ring is a tough outer layer of fibrocartilage. And inside of that concentric ring is called the nucleus pulposus, and it's more of a soft gelatinous core, and its job is to absorb shock. This area is very good for absorbing the compaction during walking or running of the spine. So the ligaments that are going to stabilize the vertebral column, they have particular jobs also. So the first one we're going to look at is the posterior longitudinal ligament and the anterior longitudinal ligament. So in between the posterior longitudinal ligament, which is here, and the anterior longitudinal ligament here, its main job is to support the intervertebral discs. The next one we're looking at is going to be the interspinous ligament. So the interspinous ligament, you can see here, they're going to be connecting from the lamina and the spinous process to the adjacent lamina and spinous process. And they have an oblique fiber type arrangement. And their job is just to maintain the alignment of the spinous process, in particular during any excessive rotation. The next one, the supraspinous ligament. This one is going to run strictly along the spinous process of the vertebral column, and this supraspinous ligament is actually starting all the way up at C7, and it's going to eventually attach going along the spinous process, and it's eventually going to attach into the sacrum. The ligamentum flavum here. So this ligamentum flavum, this is also connected into the lamina, or the inner surface between the transverse processes. So it connects the lamina to the adjacent lamina. And again, any excessive flexion or extension, it will fire to help protect the spinal cord. So when we're looking at the shoulder joint ligaments, the first one that we're going to take a look at are going to be some of the supporting ligaments. In particular, what we're going to be looking at is the accessory ligaments for the shoulder joint. And the first one is the sternoclavicular ligament. And in its name, what we're looking at is the connection between the sternum and the clavicle. This does have the ability for elevation and a little bit of depression, but every time you're raising your shoulder joint, the sternoclavicular ligament will allow the clavicle to move either in an elevated or a depressed fashion. And so you can see here in this illustration, we have the sternoclavicular ligament, which is going to move upward during shoulder abduction, which the skeleton is showing. And it's also going to be supported by the costoclavicular ligament. So the costoclavicular ligament is going to attach from the costal cartilage of rib number 1 into the clavicle. And this is just to help support the rib to the clavicle during elevation in particular. Some other ligaments that we're going to look at are primarily composed in the glenohumeral ligaments, and these are more associated with the shoulder joint. So with the glenohumeral ligaments, there's actually 3 separate glenohumeral ligaments, and the most important aspect with the glenohumeral ligaments is they have a very lax or relaxed look to them. That's what this illustration is trying to show. And they are only going to fire with excessive ranges of motion. But we're also connecting the scapula with the clavicle, and we see the different types of ligaments. So from the coracoid process of the scapula, or the coracoid process, is going to connect the coracoid process to the acromion. So we go from the coracoid of the scapula to the acromion of the scapula. And then we have the most injured ones called the coracoclavicular. We usually see these injured a lot with any overhead movements, but the coracoclavicular is going to attach from the coracoid process to the clavicle. The other one that we're looking at is the acromioclavicular ligament. It's going to attach the acromion of the scapula to the head of the clavicle. And again, we can see the structural makeup of the shoulder joint, very similar to the knee. Since this is a ball and socket joint with a lot of movement, these bursae that are located here. They are going to allow for more synovial fluid just because of the high amounts of movement that the shoulder joint produces. We also see a very common characteristic, the tendinous sheath. This one in particular is the long head of the bicep brachii. And this tendinous sheath will just allow for a nice easy tracking of the tendon when we see contraction of the bicep. I guess the last one we should mention too is the coracohumeral. This ligament is attaching the coracoid process to the humeral head. So all of these are just ligaments and general characteristics of a ball and socket joint. But they just help protect the shoulder joint due to its excessive ability to have large ranges of motion, and it will have a decrease in stability. So this is just a lateral view of the shoulder joint, and what we're going to particularly pay attention to in this lateral view is going to be how all of the tendons come in. So we see the supraspinatus tendon coming in. We also see the deltoid muscle tendon coming in. And we can see the synovial membrane here, which is producing synovial fluid. But this is a very tight compartment that all of these tendinous sheaths are coming down to attach to the humerus. And with that, we'll see that the bursa becomes really important because of all these contractions that are occurring with the tendons of the rotator cuff musculature. Another important aspect to point out is going to be how the humeral head is going to sit inside of the glenoid fossa, which is located on the scapula. So it has a glenoid labrum, and I usually refer this as kind of a suction cup. And this glenoid labrum is going to go around the outer surfaces of the glenoid cavity. And this is important because the humeral head, only 1/3 of the surface of the humeral head is actually going to sit inside of the glenoid cavity. And again, this is the structural makeup of the shoulder joint to allow for greater ranges of motion. This is why the shoulder becomes injured more easily than any other joint in the human body. But this cartilaginous ring provides kind of a suction cup for articulation in the humeral head. When we're looking at the hip joint or the acetabular joint, there are three primary ligaments that we're going to look at, or primary three. The first one is the anterior view. It's the largest one. It's called the iliofemoral ligament. And this iliofemoral ligament is actually going to bifurcate or split. So when we're looking at the iliofemoral ligament, it's this one here. So this is part of the iliofemoral ligament, and also this one. It is the largest one. And again, ligaments in the hip joint are only going to fire when we see excessive ranges of motion. The other one that we see in the anterior view is going to be the pubofemoral. So it's attached at the pubis, and it's going to then attach to the femoral, or the femur. And so we can see it kind of going here in an anterior direction towards the femur. In the posterior view, we have, again, you can see a little bit of the iliofemoral, but the one that we'll talk about most is going to be the ischiofemoral. And this ischiofemoral ligament located here is going to attach from the ischium of the pelvis to the greater trochanter of the femur. And this is the primary one that we see in the posterior view. The other one that we should look at, it's the ligament head of the femur. It's also called the round ligament. This one is connecting inside of the ball and socket, or the acetabulum, the socket of the hip. And this round ligament is actually an old artery that went into the epiphysis, and then after maturation or maturity, it actually turned into the ligament located inside of the socket of the hip. So with the knee joint, we kind of went over this part, so I'll spend a little bit more time on these two slides. We see the knee joint again with the ligamentous connection, especially in the anterior surface. We see the connection between the vastus lateralis, the rectus femoris, and the vastus medialis. All three of these quadricep muscles are going to come down and converge into what we call the femoral tendon or patellar femoral tendons. And these are a series of ligaments that are going to eventually terminate into the tibial tuberosity. When we see these quadricep femoris tendons coming down, they're going to cross over this shadowed area, which is called the patella. So we're going to have more of a medial pull coming from the vastus medialis. We're going to have more of a proximal pull from the quadratus femoris, and we're going to have more of a lateral pull on the patella from the vastus lateralis. So each one of these tendons from the muscle is going to have a significantly different type of pull. Unfortunately, what happens is the majority of the pull is going to come from the lateral side and more from the proximal. The weakest area of the quadricep tendon is going to be the vastus medialis. We also have a series of tendons, the fibular collateral. With the fibular collateral, that we're looking at an anterior superficial view of the right knee. This is going to attach from the lateral side or the fibular head, or from the femur to the fibular head. This is also considered to be called the lateral collateral ligament. On the medial side, which is the largest one, it's also called your medial collateral ligament. This tibial collateral ligament is a little bit thicker because we're more weight bearing on the medial aspect of our knee. In the back, we have a couple of other ones that are located here, and we have an oblique popliteal, which this ligament is important for protecting during initial flexion. The arcuate popliteal ligament is also located on the posterior surface connecting the femur to the posterior surface of the head of the fibula. This slide kind of gives us the major ligaments for stabilization. So when we're looking at the major stabilization, again, we're looking at the right knee. This would be the anterior surface. This one would be the fibular collateral ligament. You can see it's a little bit thinner. So this area here. You can also see the lateral meniscus versus the medial meniscus. So the medial meniscus, we're primarily weight bearing on the medial side. So this fibrocartilage or meniscus is going to be a little bit thicker. Its primary job is for cushion and support. And then you can see on the medial surface this medial collateral ligament, also known as the tibial collateral ligament. Its structural makeup is going to be a lot thicker. The primary ones that we see injured, for the most part, is going to be the anterior cruciate ligament. So the problem with the anterior cruciate ligament and the posterior cruciate ligament is that the anterior cruciate ligament starts in the posterior surface of the femur and is going to terminate at the anterior surface of the tibial plateau. And then the posterior cruciate ligament is going to primarily stay in the posterior area. Here's a better picture down here, but you can see how it's connected from the posterior surface of the femur to the posterior surface of the tibia. And what happens is during rotation, this anterior cruciate ligament that's laying over the top of this extremely strong posterior cruciate ligament gets put under excessive forces and usually is injured fairly easier under stress. Particularly what we're looking at is most anterior cruciate ligament damage occurs when the knee is flexed. So when we're looking at the knee joint, the fibular collateral ligament, medial collateral ligament, and even the posterior cruciate and anterior cruciate, their main job is to protect the knee during extension. So the weakest part of the ligamentous structures in the knee joint occur when the knee is actually in flexion. And the only protection you have with your knee during flexion is going to be your quadriceps and your hamstrings. And finally, when we're looking at the ankle joint is going to be considered the two articulating surfaces, mainly from the talus bone and the distal aspect of the tibia. And the main ones that we're going to look at is going to be the lateral ligaments. So these lateral ligaments, there's three of them. You can see one's here, one's coming off the fibula here, and one is connecting the fibula to the calcaneus. These lateral ligaments are going to primarily prevent over-inversion, the classic rolling of the ankle. Most of a low ankle sprain is going to come, I'll draw it in here, the peroneus brevis and longus tendon is going to attach to the fifth metatarsal. And this muscle is usually what we tend to injure in a low ankle sprain. And if you injure that one to a great enough degree, then these lateral ligaments will fire when you have rolled your ankle in that over inverted position, and these lateral ligaments will fire to protect mainly the talus bone. When we're looking at the posterior tibiofibular ligaments, they're a little bit higher, so we can see one in the posterior and then also one, the anterior talofibular ligament in the anterior. And usually when you hurt these are what are considered to be a high ankle sprain. So you've probably ruptured the peroneus brevis tendon, and then you're affecting now these two structures, the anterior tibiofibular and the posterior tibiofibular ligaments. And these are basically helping to bind the tibia to the fibula, and it's usually referred to as a high ankle sprain. And then finally, on the medial surface, we have a series of deltoid ligaments. These also prevent over-eversion, and they're extremely strong. So this illustration shows about 4, but there's actually 5 of them. But these deltoid ligaments are connected to the medial malleolus of the tibia. They're extremely strong. And if you do hurt these, you tend to end up breaking off the medial malleolus. And so most of the time with injuries to the deltoid ligament, we're going to see some type of breaking either in the calcaneus, or we're going to see a breaking that occurs in the tibia. And that concludes chapters 9 articulation video.